let's get right into it. Today, we are going to be focusing on those absolutely critical skills you need to master for your phlebotomy certification exam. We'll cover the essential knowledge that's going to help you ace that test, but even more importantly, it's going to ensure the safety of every single patient you work with.
So, before we go any further, let's just lock in the single most important principle in all of phlebotomy. And it's this: your number one job is to protect the patient. A perfect sample means absolutely nothing if it comes at the cost of their well-being. This idea, it should be in your head with every single draw.
Okay, so we're going to start with the heavy stuff, the most serious situations you might face. These are the ones that require you to act fast and act right. Getting this down is non-negotiable, both for your exam and for your career.
First on our list is something called iatrogenic anemia. Now that's a bit of a mouthful, but it basically means anemia that's caused by medical treatment. And in our world, that means by the blood we draw for tests. It's a really big deal, especially for our most vulnerable patients. We're talking neonates, the critically ill, and our older adults. Their blood volumes are just so much smaller or more delicate.
And when we talk about infants, the risk is incredibly high. I mean, just think about it. Removing a little over 10% of their total blood volume can be a life-threatening event. That's why hospitals have such strict rules, often limiting draws to 5% or less of an infant's total blood volume in a 24-hour period. You can bet that for your exam, knowing why you have to track draw volumes, especially with kids, is absolutely crucial.
Okay, let's switch gears and talk about something you really hope doesn't happen, but you have to be ready for: an accidental arterial puncture. The signs are super clear, and you need to spot them instantly. Arterial blood, it's going to be bright, bright red, and it will literally pulse or spurt into the tube, filling it up way faster than you'd expect. It's totally different from that steady, dark red flow of venous blood. Knowing the difference is step one. So, the second you think you've hit an artery, you need to follow this protocol, no hesitation. Step one, get that needle out immediately. Step two, apply firm, direct pressure. And I mean firm, for at least 5 minutes, and you gotta time it, don't guess. Then you absolutely have to notify supervisor and document everything. And if you did get a sample, it has to be labeled possible arterial blood. Seriously, that 5-minute pressure roll, that is a classic exam question, so lock it in. This right here, this is a non-negotiable golden rule. If your patient ever says they feel a sharp, shooting, almost electric shock-like pain going down their arm, you've probably hit a nerve. You have to stop immediately. I don't care if you have the most beautiful blood flow you've ever seen. You pull that needle out, apply pressure, and document it. The draw's over. Patient safety, remember?
All right, let's move on to thinking ahead. We're talking about patient assessment before you even think about uncapping that needle. Some patients and certain collection sites just come with a higher risk, and you've got to have a game plan.
So here are 3 classic scenarios that pop up on exams all the time. First, if a patient has had a mastectomy, you have to avoid the arm on that side, period. The risk of lymphedema and infection is just too high. Second, for patients with obesity, finding a vein can be tough. So think smarter, maybe use a bariatric tourniquet, and don't forget to check out the cephalic vein. And finally, for paralyzed limbs, it's best to avoid them due to poor circulation and the risk of blood clots. And here's a list of what I like to call no-go zones. You just should never ever draw from a compromised site. We're talking burns, dense scars, rashes, anything like that. Edema, which is that puffy swelling, is a huge one to avoid because all that extra fluid will totally dilute your sample and mess up the results. And tattoos? They can hide things you need to see, like a hematoma starting. The bottom line is always, always find a better, healthier site. Okay, so we've assessed the patient, we've picked a good site. Now let's talk about your actual technique during the draw, because even tiny mistakes here can damage a vein and, yep, ruin the sample. Here's a rule that's super simple but so important. A tourniquet should not be on for more than 1 minute. 60 seconds, that's it. If you leave it on longer, you get something called hemoconcentration. Basically, you're squeezing plasma out of the vein, which makes everything left behind, like proteins and cells, seem way more concentrated than they actually are. It's a huge preanalytical error and a favorite for exam questions.
So, you know how we sometimes ask a patient to pump their fist? Well, you're going to stop doing that. Check this out. Vigorous fist pumping can cause potassium levels to jump by nearly 20%. A 20% increase can create a panic value in the lab, making it look like your patient is having a serious medical emergency, all from one tiny mistake. From now on, just ask them to make a gentle fist. That's it.
This one is all about using gravity to your advantage. You always want to keep the collection tube positioned below the puncture site, angled down. Why? It's to prevent something called reflux, which is just a fancy way of saying the additive in the tube could flow backwards into the patient's vein. It's such a simple thing to do, and it protects both your patient and your sample.
All right, let's dive into two of the biggest reasons a lab might reject your sample: hemolysis and short draws. The good news, both are almost always preventable if you just nail your technique.
So what is hemolysis? It's basically the destruction of red blood cells. They literally burst open, and it completely ruins test results. And you know what? The most common causes are things we do: using a needle that's too small, pulling back too hard on a syringe, shaking a tube like a maraca instead of gently inverting it. It's on us as phlebotomists to prevent this.
And this is exactly why it's such a huge problem. When those red blood cells pop, all their insides spill out into the sample. Just look at this chart. It sends certain results, especially potassium, through the roof. A hemolyzed sample can make a perfectly healthy person look like they're having a cardiac emergency. That can lead to all sorts of unnecessary and even dangerous treatments. You know, for some tests, the amount of blood versus the amount of additive is like a precise chemical recipe. And the light blue top tube for coagulation tests is the perfect example. It demands a perfect 9-to-1 ratio of blood to additive. If you don't fill that tube all the way, you throw off the recipe, and the lab can't trust the results. They're just completely invalid.
And hey, it's not just the light blue top. Short draws mess things up in almost every tube. Look at this. In a lavender top, too much additive can actually shrink the red blood cells, giving you a falsely low count. In a gray top, it can cause hemolysis and throw off a glucose result. So what's the takeaway here? The fill line on the tube is not a suggestion, it's a rule. Fill it up.
All right, we're in the home stretch now. This last part is all about those final checks, the little details that prevent contamination and make sure the result is 100% accurate. Okay, time for a little pop quiz. This is a classic exam-style question. Get ready. What single error during a draw could cause a patient's potassium to look falsely high and their calcium to look falsely low? Think about what's inside those tubes. And the answer is additive carryover. It happens when you mess up the order of draw. Specifically, if you draw a lavender top EDTA tube before a serum tube. See, tiny droplets of the EDTA from the lavender tube can get carried by the needle into the next tube. EDTA has potassium in it, boom, false hot potassium. And its job is to bind calcium, boom, false low calcium. This is exactly why the order of draw is so sacred. And last but not least, let's talk about cleaning the site. Your choice of antiseptic really matters. Isopropyl alcohol is our go-to for most tests, right? But you can never use it for a blood alcohol test. That's just common sense. And povidone iodine? It's a great antiseptic, but it can actually leak into the sample and falsely bump up results for potassium, uric acid, and phosphate. So you've got to use the right cleaner for the right test.
So, we've covered a ton of ground, from handling major emergencies to the tiniest details of your technique. But it all comes down to this. Every single step you take, from the moment you ID the patient to that final tube inversion, becomes part of a story, the diagnostic story that doctors use to make life-changing decisions. Your skill, your attention to detail, that's the foundation of it all. So the real question is, what kind of story will your collection tell?